Imagine you have a brain tumor the size of your fist, which is not an uncommon size for a brain tumor, and you have to undergo brain surgery to remove it. However, your neurosurgeon tells you that in doing so, you might lose your ability to understand language for the rest of your life. That's the kind of fear that thousands of patients with brain tumors have to face every year. Although we generally know where the language area is located in the brain, which you can see in these figures represented with blue and red circles, the precise location of this function can vary significantly between patients. And as a result, it is critical to map the language area on individuals on a case-by-case basis. Currently, electrical cortical stimulation is the gold standard technique for language mapping. This procedure is carried out during surgery and it requires patients' cooperation. This means the neurosurgeon has to interrupt the surgery, wake up the patient, and ask the patient to listen to an auditory stimulus while they electrically stimulate different parts of the patient's brain. If the electrical stimulation hinders the function, they conclude that a stimulation site is involved in processing language. This procedure, however, is extremely problematic. It is expensive and time-consuming, it is challenging for clinical staff, and most importantly, it is traumatizing for the patient. Just imagine waking up in an OR with your head fixed in a place with a metallic frame while your skull is open and your brain is exposed. Because of this, many patients, and especially pediatric patients, are not candidates for this procedure. And as scary as it sounds, they have to undergo tumor removal surgery without having a proper map of their language area. To address this serious problem, I, for the first time, developed a technique to map the language area under anesthesia that does not require waking up patients during surgery. In my technique, I use brain signal directly recorded from surface of cortex using electrodes which are indicated with tiny black circles in the figure. I present an auditory stimulus to patients, and while they're awake and under anesthesia, then I analyze the signal and identify the locations in their brain that respond to the stimulus. I use this information in order to create a patient-specific map of the language area. So far, we have successfully implemented our technique on 22 neurosurgical patients, and we hope it will eventually turn into standard clinical practice. What you see here is a three-dimensional brain model of one of our patients, which I use as an example. And if you compare the two maps, it's evident that by using our technique, we can identify the language area even when the patient is completely unconscious. By eliminating the need to wake up patients during surgery, our method not only reduces the burden and risk that awake mapping poses, but also makes the language mapping available for thousands of neurosurgical patients who are currently not candidates for the problematic conventional awake language mapping techniques. Thank you so much for your attention.